I think time for us to move on to the next speaker, Dr. Neha Gupta. So ID is usually seen as the captain of the ship in multidisciplinary case approach. So how does ID steer towards it? Dr. Neha's talk will guide us through it.
A very good morning to all of you, and thank you for joining me today as we explore the importance of infectious diseases and collaboration with the other specialties here. So coincidentally, CIDS can also be collaboration of infectious diseases across specialties. And this is collaboration which brings joy, and this is a beautiful memory from the City of Joy from the last year's SITSCON. There is a very famous quote from Helen Keller, which is that alone we can do little, but together we can do a lot more. Collaboration is empowering. Collaboration is the key. Not just over drinks, but can also be over ginger tea. So today, we are going to focus on the concept of collaboration in infectious diseases. What are the various approaches for collaboration, supremacy or diplomacy, and the strategies for effective collaboration? Whatever we reap today, the seeds have been sown long time back, and the efforts is because of our pioneers in infectious diseases. And this presentation today is also built upon the presentation in 2016 Varanasi about the role of infectious diseases physician in India. And I was just fortunate to share the platform with Dr. Dilip Mathai sir. And the key roles included role of an ID in adult vaccination and travel clinic, infection control, antimicrobial stewardship, inputs to the lab, as well as management of clinical cases across specialties, and this is the focus today. Why is collaboration so important in today's world and for an ID specialist? Well, this is a very interesting article about the tale of 6 blind physicians, each one of them looking at only specific areas of the elephant, someone identifying the tail as a rope and someone identifying the ear as a fan. And this clearly depicts the scenario today in the era of super specialty. The super specialists, they have dedicated their lives for preserving the health of the respective organs. But remember, these brain, liver, kidney or the heart, they are beating inside a single body, and it is up to the duty of an ID physician or an opportunity to collaborate with all of them, come to an analysis, and then ensure a holistic patient care. So for an infectious diseases, it is a multidisciplinary collaboration. We've just seen collaboration across various specialties, neurosurgery as well as for the CNS infections. And as an ID physician, we need to collaborate for management of infections in the immunocompromised patients with the transplant as well as oncology, management of critical infections with the intensivist, MDR, XDR infections related to TB, NTM, fungal infections across the various specialties, management of various nosocomial infections, the implant-related infections with the orthopedicians as well as all the various specialties which are using implants now. Complex infections like endocarditis with the cardiology and the CTBS, UTI with the nephrologist, urologist, as well as the other infections related to bone, HIV across the various specialties, CNS infections, skin and soft tissue with the plastic surgery, intra-abdominal with the GI surgery or with the gastroenterologist. Management of POs across the various specialties. We can also collaborate regarding the dosing of the antibiotic, the renal dose modifications, as well as the various drug-to-drug interactions, and even collaboration with the pharmacocologist regarding the same can be made, which is a new concept in the field today. Providing inputs related to the appropriate test, avoiding unnecessary therapy, and of course key inputs related to the antimicrobial stewardship, infection control, as well as contribution in the teaching. So as an infectious diseases, when an intervention is done, there has been studies which have shown that an ID specialist intervention improves outcome for serious infections. And this is one of the studies which was published decade back, related, and it included close to 130,000 cases across the various syndromes. And it showed that involving an ID reduced the mortality, and it also reduced the 30-day readmission rates. and involving infectious diseases resulted in a shorter ICU stay besides a shorter or a lesser healthcare cost as well. Coming to the various approaches for the collaboration, what should be the approach? Supremacy or should we adopt diplomacy? So supremacy by definition, it is a state or a condition of being superior to all others in terms of authority, status and power. As ID physicians, we don't hanker about supremacy. For us, it is the patient's interest which is just as supreme. For diplomacy, it is the art of dealing with people in a very sensitive and tactful manner. And there is a very clever quote from Winston Churchill, which is that diplomacy is the art of telling people to go to hell in such a way that they ask for directions. We don't want anyone to go anywhere, we just want to work together across specialities, which is a way forward in this era of antimicrobial resistance. And I'm going to present this case, which is a 35-year-old gentleman with rheumatic heart disease with mitral stenosis. He underwent an MVR in 2011, and then 3 years later, this gentleman presented with PUO. And the blood culture, which was performed, showed that it was positive with Streptococcus sanguis, which was reported as probable contamination to clinically correlate. Now, this patient underwent the workup for infective endocarditis, the dental hygiene, the TOE was all negative. But as this patient was having fever, with this blood culture which was positive, the treating clinician put the patient on linezolid. There was a resolution in the fever, and then after 7 days, the linezolid was discontinued. Later, a month after, there was recurrence of fever, and that's when an ID reference was called by the CTVS surgeon. So with us, the question was, what is the cause of fever? And this positive culture, is it really a contaminant? So, as per the modified Duke's criteria, this is basically, there is a predisposing condition and there is a positive blood culture, which is Streptococcus sanguis, which is a VGS, a typical organism for IE. So this becomes a case of possible infective endocarditis. And now, what do? So as an ID, we need to collaborate with the past records and the IT. Reviewing history, which is our main armamentarium, we went back and all the 3 blood cultures were positive, making this patient a case of definite infective endocarditis. A repeat echo was performed and it showed a very large vegetation with a perforation this time. Now what next? What do? This patient is having endocarditis with this Streptococcus sanguis. Should we start this patient on vanco, linezolid, or start with levofloxacin, ampicillin, gentamicin, or streptomycin, or none of the above? So here, it's important for us ID physicians to again collaborate with a dear friend microbiologist. I think microbiology is definitely one of the best friends we have, and we requested the microbiologist for a penicillin MIC, which was 0.12. And that's when we started this patient on ampicillin gentamicin for a late onset prostatic valve infective endocarditis. So whatever the report is, again, it's important for us to diplomatically explain the reports to our colleagues as well as to the patients. And we all are aware regarding the concept of MICs for the management of IE, but the data came earlier because of this collaboration between infectious diseases and microbiology, and which was presented as a poster earlier in 2013 in ID Week regarding the antibiotic susceptibility of the Streptococcus species. And out of the 6 out of 9, 4 were intermediately resistant, 2 were intermediate sensitive, and 2 were resistant. Extending this collaboration into the other centers, the microbiological profile of infective endocarditis cases, which was presented as a poster of infectious diseases, a friend in need for infective endocarditis in SITSCON 2015. Out of the 32 cases, among the culture positive cases, the most common is VGS and enterococci in our setting and not MRSA as we see in the West. And all this has implications on the antimicrobial stewardship. There was modification of the antibiotics following the infectious diseases consultation, in 25 out of the 32 patients, and de-escalation of antibiotic from broad spectrum meropenem BLBLI combination to a narrow spectrum, which is indicated by the blue bars of ampicillin or ampicillin sulbactam with gentamicin or the dual beta-lactam therapy was done in 12 patients, which significantly resulted in a decrease in the cost. And the few inputs which are given on a daily basis and the collaboration resulted in, for any patient in cardiology, CTVS, calling for an ID opinion for fever, infection or endocarditis. Moving on to another case, this is a 42-year-old gentleman with abdominal pain for 2.5 years, CT scan showing abdominal lymphadenopathy, CT chest showing centrilobular nodules, which was reported as probable tuberculosis. Biopsy was granulomatous. ATT was initiated, but he was not tolerating the ATT. He had severe nausea, and that's when ID reference was sought by the gastroenterologist. And when we looked back, the history was there was no constitutional symptoms, and he was also having some ankle pain for 3 years, making a close differential of sarcoidosis. So there is collaboration with the radiologist for the management of various infections, and the centrilobular nodules, the non-necrotic lymphadenopathy, as well as the thickened pericardium could also be seen in sarcoidosis. And this, with the histopathology showing the non-cacheating granulomas, clinched the diagnosis. Another interesting case, this is a patient, a young lady presenting with PUO. She was started on poly-B, meropenem, linezolid, and also she had this left-sided empyema. There was collapse and consolidation, underwent VATS surgery, and the histopathology report had yeast forms of candida, and the impression was of candidiasis. For this, she was initiated on echinocandins and still was not responding. Fever was persistent, and that's when an ID was called in. So here, when we looked at the report, there is candidiasis, but we know that candida pneumonia is not common at all. So what could it be? We requested our histopathologist to just, can you please review the slides? Do you think it is this, or it could be something else? And he did come back very sweetly. It was budding yeast, but histoplasmosis. So the impact of this collaboration is that all the broad spectrum antibiotics were discontinued, and the liposomal ampho-B, which is for histoplasmosis, was initiated. So it's very important as an ID to make the referring doctor feel that he's almost correct, hiding the fact that the difference between correct and almost correct is wide. And this is the core of our specialty as well, that the difference between the most appropriate treatment and the closest alternative is wide. And this makes the management of these infections both challenging as well as rewarding. Moving on to neurosurgery and the collaboration, just extending from what Dr. Vishnu has presented, this is a 27-year-old boy who had a recurrent pituitary macroadenoma, and he was operated for the same. Post-op, he developed the CSF rhinorrhea, as well as, and for this, the endoscopic transnasal CSF leak repair was performed. A few days later, he presented with acute meningitis, where the Gram-Stain and CSF cultures were negative, but he had responded to meropenem and vancomycin, which was initiated by the neurocritical care team. Now, he underwent several neurosurgical procedures like lumbar drain, as well as LP shunt was done, and meanwhile, he also had complications, severe headache, which also had this very significant pneumocephalus, and while in the hospital, he developed high-grade fever again, and the CSF was suggestive of meningitis. He was already on meropenem vancomycin. To this, colistin was added. Still, the fever was persistent, headache was severe, and that's when an infectious diseases was called in by the neurosurgeon. This patient was running very high fever, but on examination, he was not toxic. On examination of the nasal cavity, there was a nasal discharge which was seen, as we can see here, and we quickly took the swab from here, and the gram stain showed this budding yeast cells. So for us, this patient is not responding to the broad spectrum antibiotics, and this becomes significant, but And it was easier to convince a neurosurgeon, but it was a little uphill task to convince the neurocritical care team, because they said it's really not growing in the CSF. Do we really have to start him on liposomal amphoby? But yes, a little tactful, diplomatic manner, we said, okay, we started, and then let's just see what happens. So we started with the liposomal amphoby as well as 5FC, and the cultures grew Candida albicans. So subsequently, once this patient is on effective antifungal therapy, all the other surgical procedures which were failing earlier could be performed. He underwent a successful endoscopic CSF leak repair, LP shunt was also done, and then subsequently discharged on fluconazole. So ours is a service specialty. We provide service for successful surgeries, transplant, implant, and cancer chemotherapy. Ours is the only one that actually cures the disease. We cure, and we want patients to be followed up with the referring physician. So ID is not a threat. It is in fact a friend in need. Like we have syndromic approach to infectious diseases and the principles for choosing the antibiotic therapy, we also can consider syndromic approach to collaboration, and there are certain low-hanging fruits like the surgical specialties and certain ID domains like HIV and sexually transmitted diseases, NTM, TB, and fungal infections, which are easier to collaborate. And like this patient who was referred by the plastic surgery for the multiple subcutaneous abscesses, she was really not having fever and not responding to the linezolid as well as and antibiotics before. The biopsy was suggestive of necrotizing lesion, and the cultures were not sent earlier, and then referred. And when we reviewed, it's always collaboration with the past records and the history. She was working in the microbiology lab in AIMS, and the abscesses were cold abscesses. So it was rather easier, but it was like we did the CT scan which suggested necrotizing lymphadenopathy, centrilobular nodules, and the gene expert detected the MTB. Now moving on to this interesting case again, which is of a 73-year-old lady. She had undergone bilateral TKR in 2021 for osteoarthritis. And then later, almost a year later, she presented with acute onset fever with backache, hip pain, and breathlessness. She had developed consolidations in the chest, consolidations as well. And this was a case of MRSA, community-acquired bacteremia. This patient was initiated on teicoplanin and clindamycin. She was clinically better, afebrile. The repeat blood cultures were also negative, but there was a progressive leukocytosis and the counts were going up till 39,000, and the biomarkers of inflammation were also not coming down significantly. So this, as an ID, there was a strong suspicion of complicated Staph aureus bacteremia and prosthetic joint infection, and we advised for a MSK USG. But my orthopedician friend called up and said, Neha, why are you writing a MSK USG? I don't think it is a PGI at all. So for the first time, after so many years, actually the bell started ringing, and I was like, okay, implant in an ID out, do I have to face this? And probably at this point, I diplomatically adopt the withdrawal approach of the Ranchor Lord Krishna. Well, this obviously doesn't come in 30s, it comes with some age and experience. And I said, okay, so maybe we rule out other infections. And if there's no infection, we proceed with some other investigations. And the MRI was performed, which showed that there was effusion around the knee joint. Still, a needle was not placed in because of the risk. He was worried about the risk of infection. So a WBC scan was done, and it lighted up around the knee joints. And the BGI, subsequently the aspiration was done, and the BioFire JI panel detected the MRSA. The patient underwent surgery and the surgical debridement immediately. Now this is another case of a patient who had implants in situ, and he had this pus culture which was positive for the Pseudomonas aeruginosa. He had been mildly asymptomatic for 9 years, very bad surgical risk. So what do we do? Now this is a case that Soman sir has provided. So what do we do? So do we accept defeat in this case because it's a bad surgical risk, and don't treat, removal of the implant should not be done, and of course there's no need to start on polymyxin. So sometimes it's about individualized therapy, and we have to be in diplomacy even with the bugs. Like this case, it is Pseudomonas. Coming to the strategies for successful, effective collaboration, we all have seen collaboration of infectious diseases, especially with the transplant team, with the ISOT, and of course with collaboration with the various other microbiology as well as the other societies. And this is one of the global guidelines for the management of mucormycosis, which is also a very good collaboration with the medical mycologist and the leading infectious diseases specialist, and even the cryptococcal guidelines are coming out. So if we enumerate the strategies, it is communication which has to be accurate and through various channels. It can be through meetings, emails, instant messages, collaboration platforms. And it's very important to have a multidisciplinary approach for the various clinicians as well as for the lab experts. Teamwork and leadership, it's important to foster a collaborative culture that values teamwork, respect, and shared decision making. And I think we take the example of Apollo ID Chennai, where there are so many consultants, they are working together. Data sharing, analysis, joint research projects, which are of course with the ICMR and the other bodies, it is going on. Regular meetings and conferences, networking, information exchange and education, making policies as well as advocacy, and of course international collaboration. And it's important to continuously evaluate the effectiveness of these efforts. While we are all collaborating, and of course we are now living in the world of AI as well, there are several point of care tests which have also, or the newer diagnostics which have come, and it's important to collaborate with them as well. As a physician, in the OPD, I think most often we see a fever, URTIs, and it's often difficult to differentiate whether it is a viral infection or a bacterial infection. So certain biomarkers, which even Dr. Vinay alluded, can be used for making our treatment decisions, and CRP, which can be detected in just 3 minutes by this POCT, can help us in differentiating between viral and bacterial. And it's important for, as an ID, to collaborate with the novel diagnostics as well. To summarize, infectious diseases present with complex challenges that require a multidisciplinary approach. Collaborating across specialties strengthens the patient care, enhances diagnosis and treatment, and improves overall outcomes. By working together, we can leverage the expertise of various professionals, exchange the knowledge, and ultimately make significant strides in combating the various infectious diseases. And we all are aware that it is the collaboration across specialties which will bring success, and it has to be a very long-term strategy. Thank you so much.
Thank you, ma'am. Thanks for that excellent presentation. We can allow for 1 or 2 questions, please. There is no further questions. We'll disperse for tea break and reassemble at 11:15 a.m. And for all, there's one announcement for all the delegates who have posters. Please mount your posters at the slot given now, so that they will be judged accordingly. Thank you.
Thank you so much.